In this video, we will review the ACTH or cortrosyn stimulation test in both the diagnosis of adrenal insufficiency and nonclassic congenital adrenal hyperplasia, recent changes to the cutoff limits of the cortisol assay, and optimal testing conditions. The ACTH stimulation test is performed to determine if the adrenal glands can respond appropriately to exogenous ACTH. I recommend that you review our other video on the basic physiology of the hypothalamic pituitary adrenal axis if you are interested in understanding cortisol regulation in normal physiology. In patients with primary adrenal insufficiency, serum cortisol is low in the setting of elevated adrenocorticotropic hormone levels. Furthermore, the 24-hour urinary cortisol excretion is low in patients with adrenal insufficiency. A helpful rule of thumb is that in symptomatic patients, an 8 a.m. serum ACTH concentration greater than 500 picograms per ml and a concomitant serum cortisol concentration less than 5 micrograms per deciliter is diagnostic of primary adrenal insufficiency. In this setting, an ACTH or cortrosyn stimulation test is unnecessary. In preparing for this test, patients should be instructed to hold off glucocorticoids for at least 24 hours before the test, since common exogenous steroids such as hydrocortisone and prednisone are detectable on the cortisol assay. There are some additional caveats in performing this test. It is essential to understand the role of binding proteins on total cortisol assessment. Total cortisol, which is a form of cortisol measured on most immunoassays, is estimated based on this equation. The total cortisol is equal to free cortisol plus bound cortisol. Forms of binding proteins for cortisol include corticosteroid binding globulin, CBG, and albumin. Consequently, clinical states that alter these binding proteins can affect the measured value of total cortisol in plasma. For example, oral estrogen increases corticosteroid binding globulin, which results in the elevation of total cortisol levels. The mechanism is beyond the scope of this video. Furthermore, patients with low serum albumin, usually below 2.5 grams per deciliter, will have low total cortisol. This is because albumin is a major binding protein for cortisol. So, can the cortrosyn stimulation test differentiate between primary and secondary adrenal insufficiency? The answer is no. It is simply a test to evaluate the ability of the adrenal glands to respond to exogenous ACTH stimulation. Although the test has a high specificity for both primary and secondary adrenal insufficiency, it has a very low sensitivity for secondary adrenal insufficiency. And why is that? This is because within 3 months of developing secondary adrenal insufficiency, the adrenal cortex remains responsive to exogenous ACTH stimulation. For this reason, even if a patient has secondary adrenal insufficiency, the ACTH or cortrosyn stimulation test may return falsely negative within the first few months of developing adrenal insufficiency. This is because although there is limited ACTH stimulation of cortisol production in secondary adrenal insufficiency, the adrenal cortex may take up to 3 months to develop significant atrophy. Consequently, when exogenous ACTH is administered, the adrenal cortex continues to maintain a sufficient response. The materials needed for the test include 3 gold top tubes. They should be labeled for the collection of serum cortisol at baseline, 30 and 60 minutes. The test can be performed in either the outpatient or inpatient setting. A venous blood sample is drawn to assess baseline cortisol. 250 micrograms of cortrosyn, a form of synthetic ACTH, is administered either intramuscularly or subcutaneously. Repeat blood samples are drawn at 30 and 60 minutes. So how is the test interpreted? A normal response shows a peak stimulated cortisol level greater than 18 micrograms per deciliter at either 30 or 60 minutes. When the corticotropin stimulation test is performed in patients with primary adrenal failure, the serum cortisol concentration does not change from baseline. The baseline value is typically less than 5 micrograms per deciliter, and the increment after corticotropin stimulation is typically less than 7 micrograms per deciliter. The peak value also remains below 18 micrograms per deciliter. In secondary adrenal insufficiency, the increment after corticotropin administration is also less than 7 micrograms per deciliter, and the peak value remains below 18 micrograms per deciliter. The traditionally accepted cutoff value for post-stimulation cortisol, that is 18 micrograms per deciliter, was based on polyclonal antibody-based immunoassays. In recent years, immunoassays such as the Roche Elixis 2 assay is based on a monoclonal antibody with a much lower detection limit for cortisol. Consequently, when using these newer assays, the acceptable post-stimulation cortisol level, especially at 60 minutes, is anywhere from 14 to 15 micrograms per deciliter and not the traditional cutoff of 18 micrograms per deciliter. As you may recall earlier in this video, low serum albumin can artifactually reduce the measured total cortisol. For patients with expected low total cortisol, such as those with chronic liver disease, free cortisol instead of total cortisol should be measured at baseline 30 and 60 minutes. A normal response is a peak stimulated free cortisol value greater than 1.2 micrograms per deciliter at either 30 or 60 minutes. This is not exactly the end of the clinical utility of this test, since it is also a screening test for 21-hydroxylase deficiency, a cause of nonclassic congenital adrenal hyperplasia. This is a milder form of congenital adrenal hyperplasia, which may result in oligomenorrhea, infertility, and hirsutism in women. The test is best performed in the early follicular phase of the menstrual cycle in women being investigated for hyperandrogenemia. Also, oral contraceptive pills should be discontinued for at least 8 weeks before the test. In this test, both 17-hydroxyprogesterone and cortisol are drawn at baseline. 250 micrograms of cortrosyn is then administered intramuscularly. Samples of 17-hydroxyprogesterone and cortisol are then drawn at 60 minutes. If the basal 17-hydroxyprogesterone is less than 200 nanograms per deciliter, then the diagnosis is highly unlikely, as such an ACTH stimulation test is not necessary. If basal 17-hydroxyprogesterone is greater than 10,000 nanograms per deciliter, then this is highly suggestive of classic 21-hydroxylase deficiency. For patients with basal 17-hydroxyprogesterone between 200 and 10,000 nanograms per deciliter, an ACTH stimulation test is recommended. How is the ACTH stimulation test interpreted in the evaluation of nonclassic congenital adrenal hyperplasia? If the 17-hydroxyprogesterone level at 60 minutes falls between 1,000 to 10,000 nanograms per deciliter, this suggests nonclassic CAH. If the stimulated 17-hydroxyprogesterone at 60 minutes is less than 1,000 nanograms per deciliter, then the patient is either unaffected or is a heterozygote. If the stimulated 17-hydroxyprogesterone at 60 minutes is greater than 10,000 nanogram per deciliter, then the patient has classic 21-hydroxylase deficiency. This concludes the video on ACTH stimulation test. I hope you found this helpful. If you want to see more of our videos about endocrine pathophysiology, then hit the subscribe button. Do not forget to click the bell icon so you will be notified when future videos in endocrinology are uploaded. Thanks for watching.